What if I told you that most diagnostic mistakes in dentistry don't come from what we do, but from what we don't see on our 2D x-rays? And here's the surprising part. Every dentist learned 2D radiology in dental school, but very few learned how to interpret images with clinical confidence. Welcome to the look phase of the Devigus method. Today we start with the foundation of modern diagnostics, understanding, analyzing and trusting your 2D dental radiographs. In dental school, we were taught the technical basics of 2D radiography, how to take an X-ray, which projections to use, and what the standard anatomy looks like. Today, we reconnect with those essentials and add the clinical reasoning layer that was never fully explained, or maybe never fully explained. We all learned the types of radiographs: bite wings for caries and bone levels, periapicals for roots, periapical status and endodontics, occlusal images for localization on large lesions, extraoral images like panoramics for overview and asymmetries. We also learned technical factors. PVP controls penetration, A controls density, angulation determines distortion, receptor placement affects projection. All true, but none of these prepare you for real diagnostic interpretation. We memorized anatomical landmarks: the lamina dura, PDL space, alveolar crest, cortical borders, sinus floor, the nasopalatine canal, the mental foramen, important structures, but we were rarely taught how these landmarks help us avoid false diagnosis. And this is the big gap. Dental school taught the what, but not the how. You learned what structures look like, but not how to interpret patterns, how to reason for imaging, or how to connect 2D information with clinical findings, photography, or 3D scans. So let's build that foundation now. There are 3 core principles you must master in 2D imaging. Principle number 1, projection changes everything. Every X-ray is a projection. One change in tube angle can make a root seem curved or straight, shorter or longer, or make a lesion appear or disappear. Principle number 2, anatomy first, pathology second. You never diagnose pathology before confirming normal anatomy. Your anchors are the lamina dura, the PDL space, cortical borders, the crestal contour, and the symmetry from right to left. Everything else is a variation on these anchors. Principle number 3, diagnose patterns, not pixels. Dental school taught us to look at dark spots, but in real diagnostics, isolated radiolucencies mean nothing. We diagnose from patterns, symmetry, borders, density, shape, continuity, and correlation with the clinical examination. Let's look at the 5 most common misinterpretations. Number 1, cervical burnout mistaken for caries. Number 2, overlapping contacts hiding caries. Number 3, lesions that are a projection artifact. Number 4, roots that look short but are actually distorted. Number 5, early periodontal changes that go unnoticed because they are very subtle. Now let's connect this to the Devigus method. Here's the 4-step workflow I use every day for 2D interpretation. Step 1, orientation. What projection is this? From which direction? Which structures should appear? Step 2, anatomy check. Find your anchors. If anatomy doesn't match the expected angle, something is wrong. Step 3, pattern analysis. Shape, symmetry, borders, density, progression. Step 4, correlation. Use all available data, clinical photos, probing, symptoms, CBCT, and scans. This is the look phase in action. We don't just look at images, we look through them. 2D imaging gives us the context we need before we move into CBCT and AI. And that brings us to the next lesson. In the next video, we move from 2D to 3D imaging with CBCT. And I'll show you how to navigate volumes, what slices matter, and how CBCT changes your diagnostic confidence. If you want to master modern diagnostics, follow this playlist step by step. And if you have any questions about the interpretation of 2D X-rays, ask in the comments. I will answer with a dedicated video. Welcome to the look phase of the Devigus method. Voila!